Low back pain exams can feel overwhelming. There are dozens of orthopedic tests like straight leg raise, slump, Kemp's, and many students try to memorize all of them for OSCEs. But experienced clinicians don't actually approach back pain that way. Instead, they use a few key diagnostic forks to narrow the problem quickly. In this video, I'll show you the ScrubNotes clinical framework that helps you move from low back pain to a focused diagnosis in just a few steps. And later in the video, I'll show you one more exam shortcut that quickly distinguishes mechanical back pain from nerve root involvement. At ScrubNotes, we approach every chief complaint using the same three-step framework. Safety first, so could this be something dangerous? Second, we look for patterns. What clues in the history and exam narrow the possibilities? And third, key diagnostic forks. These are the decision points that guide which tests we actually run. That's the approach we'll use for this case of a 42-year-old male with low back pain. The first step when someone presents with low back pain is to start with clarifying the complaint. Where exactly is the pain? Did anything trigger it? Does the pain radiate down the leg? And at the same time, we can screen for red flags, things like severe trauma, saddle anesthesia, bowel or bladder dysfunction, progressive neurologic deficit, fever or infection risk, and a history of cancer. These findings could indicate serious pathology. For example, saddle anesthesia or bowel and bladder changes raise concern for cauda equina syndrome. So before anything else, we make sure there are no dangerous causes of back pain. This is our starting differential list for low back pain. Instead of memorizing dozens of diagnoses, it helps to group them into a few major categories. Mechanical causes like lumbar disc pathology, lumbar strain, facet joint irritation, SI joint dysfunction. Neurological causes like lumbar radiculopathy, spinal stenosis. We can always keep serious causes in mind too, like cauda equina syndrome, fracture, infection, or malignancy. The goal here isn't to memorize everything, it's to identify which bucket the patient likely falls into. Low back pain is not so much a localization problem as it is a risk stratification problem. So we want to figure out if the patient fits into more of an emergent pattern, more of a concerning pattern, or they have a stable pattern. I've provided some criteria here to help you determine which of those fits best. The history already gives us powerful clues. One of the most powerful questions is, where exactly does the pain travel? Pain patterns narrow the differential significantly. Central lumbar pain often suggests muscular or mechanical causes. Pain radiating down the leg raises concern for nerve root involvement. We can also ask pattern questions like, does flexion worsen the pain? Does extension cause more pain? Does sitting or coughing reproduce symptoms? For example, pain with flexion often indicates disc pathology. Pain with extension may suggest facet joint irritation. Let's apply this framework to a case. A 42-year-old warehouse worker presents with 5 days of low back pain. The pain began suddenly after lifting a heavy box at work. He describes sharp pain in the lower lumbar region that radiates down the right posterior thigh and calf. The pain worsens with sitting, bending forward, and coughing. He also reports intermittent tingling in the right foot. Importantly, he denies weakness, saddle anesthesia, and bowel or bladder dysfunction. Already we have several important pattern clues. Before we jump into orthopedic tests, we run what I like to call the ScrubNotes MSK algorithm. So first is the pre-3 safety screen. Then we look for pattern clues in the history and motion exam. Next comes a diagnostic fork, in this case determining whether symptoms suggest nerve root involvement. And then only after we do all of those, we run targeted orthopedic clusters. This stepwise approach prevents us from running random tests and helps the diagnosis emerge much more efficiently. If you want a quick reference for this exam flow, I've organized the Pre-3 framework and orthopedic clusters in the ScrubNotes Orthodex. The Pre-3 is our structural and safety screen. It answers 3 important questions. First, we use observation to look for any asymmetry, guarding, antalgic posture, or spinal deformity. Second is fracture screening, where we palpate and percuss the spinous processes. Third is active range of motion, where we assess flexion, extension, lateral flexion, and rotation, which can give important pattern clues. For example, pain with flexion often suggests disc pathology, but pain with extension can suggest facet irritation. The key idea is this: before focusing on special tests, we confirm the spine is structurally safe to examine further. Remember earlier when I mentioned a shortcut that helps distinguish mechanical back pain from nerve root involvement? Well, this is it. After the pre-3, we perform a neurologic screen. We check dermatomes, myotomes, and reflexes. If symptoms radiate down the leg, especially below the knee, that strongly suggests nerve root irritation. This diagnostic fork dramatically narrows the differential list. Okay, so now we can actually start to run targeted orthopedic tests. For suspected disc or radiculopathy, we use straight leg raise, slump test. For facet irritation, extension plus rotation, or Kemp's test, is helpful. For sacroiliac pathology, you could use Faber and compression or distraction tests. Again, the key idea here is that we choose clusters based on earlier findings rather than just running everything we can think of. If you want quick visual summaries for these clusters across the spine, shoulder, knee, and hip, I've organized them into the ScrubNotes OrthoDex link below. Let's circle back and see how our framework applied to our case. The pre-3 shows no signs of fracture or instability. However, the patient reports pain radiating down the posterior leg. Neurologic screening reveals decreased sensation and a dermatomal pattern, and the targeted tests show a positive straight leg raise and a slump test, which reproduce the patient's symptoms. When we follow the framework, the pre-3, neurological screen, and targeted orthos, the pattern strongly suggests lumbar disc pathology affecting the nerve root. So, putting everything together, we have a patient with acute low back pain after lifting and radiating pain down the posterior leg. The history shows symptoms worsened by flexion, sitting, and coughing, which increase disc loading. Exam reveals a positive straight leg raise with reproduction of radicular symptoms and mild dermatomal sensory change. The presentation is most consistent with lumbar disc herniation causing radiculopathy, likely involving L5 or S1. Importantly, there is no evidence of fracture, infection, malignancy, or cauda equina syndrome. Before we wrap up, I wanted to share 3 mistakes I see students make all the time with low back pain exams. First, skipping the neuro exam. Second, failing to distinguish flexion versus extension pain patterns. Flexion bias suggests disc pathology, extension bias suggests facet irritation. And third, ignoring red flags like saddle anesthesia or bowel and bladder dysfunction. If we fix those 3 things, back pain exams become much more thorough. To summarize the ScrubNotes MSK framework, first, run the pre-3 safety screen. Next, look for radicular patterns or neurological findings. And finally, run targeted orthopedic clusters like straight leg raise or slump. When low back pain radiates below the knee and nerve tension tests are positive, the most likely diagnosis is lumbar disc herniation with radiculopathy. Once you start thinking about back pain using these diagnostic forks, the entire evaluation becomes much easier. If you want quick reference versions of the pre-3 framework and orthopedic clusters, those are all included in the ScrubNotes OrthoDex linked below. Thanks for watching, and if you found this helpful, check out the rest of the ScrubNotes Chief Complaint Series where we break down other common clinical presentations the same way.